perhaps need to know the answer to, let's go over it and just make sure at this stage that we do it, because the actual techniques are going to be fundamentally quite simple. You know, just move it up here, move it that way, rotate it this way. I mean, we run very simple techniques, but in actual fact the reasoning behind the whole thing is so important as to when we can do them, and that's what we should be doing in this area. So just have a look at this picture from Kapanji, of course, and the only thing that I want to illustrate from this particular picture is this, that what we can't see on this diagram is the clivus, because of course we're seeing the lateral mass here. The clivus, if we could look on the inside edge of this and see the foramen magnum, then the clivus is this little bit on the front of the foramen magnum. That little bit here is called the clivus. Okay, so that when we go into a flexion, you can kind of see that as I flex and there's a backward motion of the occipital condyles like that, Wern described the restriction of flexion of this joint, notwithstanding the big ligaments about at the back, but of the central joint here, to be a bone-to-bone contact of the clivus against the dens. And he described a small bursa there that he said illustrated that there is some contact. Now, where the bursa lies in relationship to the apical ligament, and what the apical ligament does under these circumstances, he failed to describe. But when we go into an extension movement, as we see here, and the condyles are sliding forward, the clivus is going to be taken forward now, as you see, of the dens, which means that any structure that passes over the back of the dens to get to the clivus will be taken into tension on this extension motion. Now, if we continue with this, if we look at what happens possibly in the tilting that occurs, and we should discuss this because it would appear that flexion and extension can't occur there, but we know that it can, that as I go into a flexion motion there, once again, if we take a female motion of the atlas against the axis, that also takes the clivus away from the dens, which tightens up those ligaments. So when we're thinking of those longitudinal ligaments, they would be taken into tension, wouldn't they, if we extend the occipito-atlantal joint and flex the atlantoaxial joint a little. That would be the tension thing, and then we could kind of lift it in that particular position. But of course, when you look at this, what are the other structures? Now I just want to sort of, you know, not be a devil's advocate particularly, but just kind of go over a few points, not just a straightforward lecture. But as I'm doing a distraction like this, what other structures are very important for resisting this? That we always tend to forget. Yeah? What else? Pardon? Muscles. Yes? What else? The capsules. And the capsules of the occipito-atlantal joint and the capsules of the atlantoaxial joint are very strong structures. And we've also got, particularly around the occipito-atlantal, two collateral lateral ligaments, which are quite strong. So when we're talking about the alar ligament and all this business, and whether it's been damaged, I think it's already mandatory to accept that what's also damaged are these capsular structures and probably the muscles working around this area as well. And they may be, because of the derivation of information from those structures, far more important than the alar ligament. The alar ligament shows the damage, but also we've got all the damage in the capsules that has to go on for those movements to have actually been produced. And we tend not to talk about that. We tend to stick with all these interspinous ligaments. And I'm going to ask you a question about the source of proprioception from ligaments. Because if we feel unstable, what's giving us the instability? Is it the alar ligament that's not signaling? What's your feelings about this? What have you been considering about this?
Joint mechanoreceptors.
Yeah, much more. I mean, what are ligamentous receptors? When do they work? Yeah. And it's a protective thing. They act like the GTOs. They've got a very high threshold, which is no good for proprioception. They're not going to sense small changes in movement. And then they are continuously active once they've been fired. Now the question is, have any of the ligaments in the spine got any of these ligamentous receptors? Weick used to sort of absolutely categorically state that the longitudinal ligaments of the spine hadn't got any ligamentous receptors in, but he also told us categorically that the disc hadn't got any innervation as well. So he's wrong on that, perhaps he's wrong on some of the other. But in fact, most of the information in terms of proprioception from the occipito-atlantic, or from the craniovertebral area, comes from what? And which part of the muscles, Boyd? Yes, the neuromuscular spindles. You know, and when we damage this area, all of that lot, there's a lot of bleeding, there's the damage in the capsules, and we tend to kind of concentrate on these ligaments rather than on these other structures that have been badly damaged. And that's probably where a lot of the source of misinformation is now being given to the brain. So this is something for us to remember. Okay, let's continue with this just very, very quickly. If we look at the motion of the rotational motion, let's just look at the two obvious movements of this area, and I don't need to sort of talk about this very much. We've got quite visible on there, and it looks much more visible when you see a recent specimen than necessarily it does when you see a bony specimen. On bony specimens, very often it doesn't look like this convex surface, but when you see the thickness of the articular cartilage on a recent specimen, it's definitely biconvex, no question. All right, now what is the important thing about this, I think, is it's a very funny thing that it would seem that the bones are the most unstable in the most usual position, which is when we're just looking forward like this. They're up on the condyles. I can't do my hands around like that. Up on the condyles like this in the neutral position. And when we rotate, there is that descent, isn't there? Then it comes back up to the neutral, and then it descends. And this is one way also which the descent of the atlas on the axis means that the distance between the dens and the occiput is reduced, so that when we're turning, that alar ligament mechanism again can retain its tension but still allow the movement because of this descent up to the neutral when it doesn't keeps that optimum tension, and then it descends down again like this. Now the important thing here, as far as I would be concerned, in terms of pathological significance of all of this, is this business here, where this is coming forwards on the contralateral side, so that it ends up, as you see in this diagram here, oh, you don't see it in that diagram there, but as it comes forward, it would now, if we were looking down from above, jut out over the front here on the contralateral side, and this one would be back on the ipsilateral side here. Now, what's so important about that particular thing in terms of rotation? If I were to ask you how significant that is to us as mobilizers and manipulators, what would you say? Yes? Can you talk a little bit, Don, about stiffness and its consequence in terms of mobilizing?
You can't get to the full end of rotation, then you're not fully stressing the vertebral artery. It's not an adequate test.
Oh, okay. I'll accept that, but that's not what's in my mind, so you've got to have another go.
What was the question again?
What is the significance of this movement, this rotary movement that we've got, or this backward movement, forward movement, in terms of the vertebral artery, if you like, but in terms of the consequences for mobilizing? We've got a stiff rotation. Let me set this up for you. We've got a stiff rotation to the right. Now, what really matters to us when we discuss or decide on this stiff rotation to the right? Is it good enough for me to get hold of this and rotate it to the right? Because that's what was done for many years. Just, okay, right rotation restriction, let's get to the right and let's move it. But you're the new breed. I'm still the old breed, so I know the answer a bit better, because you're horrified at this.
Which structure is it that's the type, that's the limiting?
Yes, or which side is the limiting thing, all right? Now, would you say for our purposes in terms of serious consequences that it would matter if it was the contralateral side that wouldn't move forward or the ipsilateral side that wouldn't move backwards? Which would be the worst? And I've had this problem for several months, okay, of restriction. I've been trying hard because my job means I have to keep turning, and I've been doing this. And I didn't see my doctor because I thought it would go away. It didn't go away. So I've been straining around like that. Now, which would be the worst for me? If it's the one on this side that won't go back or the one on that side that won't come forward?
Well, we got a 50% chance here, I guess. The one,
Go for it.
the one that won't go backwards.
Why? What do we know, first of all, about when we've got a stiff facet? What does that stiff facet become?
Arthrotic?
No, it becomes the axis of movement, doesn't it? So here we are, we've got this, the axis of movement, and if this won't go back, what's going to happen on this side? Okay, it's going to become hypermobile on that side. Now, what does hypermobility on this side, what consequences does that have? There's two major consequences. Ask your group. Everybody can ask their group. 1 minute to ask the group.
It's going to be progressive.
If you're looking at it, what you are going to see is go to the right. This guy's blocked. The one that was, yeah, well, whatever that last one.
So you have a lot of activity and so on. That side probably.
Well, this one from what I read last night.
Tear the liver deeper.
In rotation to the left of the
So it was
opposite.
all the time.
Okay, Don, you're on again. Step forward.
Changes the axis of rotation and putting further stress on the contralateral vertebral arteries.
That's correct. Because the problem with the vertebral artery, generally speaking, is at C1, 2. And when we look at any pictures, and there's plenty of pictures in the text that I've given you in the articles, that when we turn this side, this one, which we can demonstrate on this perfectly well, this one has a major kink placed in it. Whereas when we look on this side, the ipsilateral side, it just straightens it out. Not any great problem, but you look at this side and there's that major kink on the artery. And if this is getting more and more mobile and swinging forward like that to try and make up this rotation, working around this fulcrum, instead of the fulcrum being central, then there's a lot of leverage going to be placed on this. So it's very significant. Then if it were on this side was stiff, well, the chances are that this side's not going to get very hypermobile. Now, what's the other consequence if this one keeps coming forward? Yes, the transverse. You're on the ball today, Bob, that's great. So as we take this forward, we're obviously putting stress on the transverse ligament. Whereas when we go backwards, if I get hold of this one, when I have a stiffness going on the backward gliding one, then all it's going to do is to just take the anterior arch into the dens. Not a great difficulty.
Say that again.
Yes, that when if it's the stiff side is on the ipsilateral side, then it's going to go back into a very stable position with the dens and the anterior arch of atlas getting closer together. All right? Where it's on this side, it's going to pull it apart like that.
I thought the stiffness was on the ipsilateral side and the excessive motion was on the contralateral side.
Yeah, and then we sort of said, now what's the consequence? You must have just fallen asleep there, Sandy. What is the consequence when it's on the contralateral side? Okay, is it possible for the ipsilateral side to get hypermobile backwards? The chances are it won't, because it's going bone against bone, so it won't have a great deal of consequence.
And is your ultimate concern damage to the transverse ligament, or is your ultimate concern what damage to the transverse ligament would do to the cord?
Both of those.
Okay.
And creating...
Two things.
Oh, no. Okay, no, the two things were the vertebral artery and then the consequence to the transverse ligament, just making it slacker.
But the ultimate concern about the transverse ligament being slack is that then the dens, you can have damage to the cord.
When we flex.
When you flex.
Yes. Whether it's damage to the cord or... I think there are subtler signs than damage to the cord. You sometimes see these in children. Okay? And this is kind of an important thing. It was described by Guttmann from Germany a long time ago, and this was called anteflexion. That's A-T-A-N-T-E. Anteflexion headaches in children. And anteflexion, of course, is that movement, as opposed to retroflexion, which was that movement, all right? And so we had children that had, this was the headaches that children got during the week when they had to go to school that they didn't get at the weekend. So what do you say about this? Don't like school. But what was it? It was that when they were writing, the head was forward like this. And if there's laxity of the transverse ligament, they've got that dens just pressing lightly, presumably, on the spinal medulla, causing headaches and all kinds of problems. So these were children that... There were two groups in Germany that worked quite distinctly and came up with exactly the same conclusion. One was a group of ophthalmologists and one was a group of manual medicine physicians. And they came up to the conclusion that what had happened was the modernization of schools had created this, because in the olden days we used to have desks that all were tilted like this. And then we got away from the tilted desks down to here. So now you have these kids who's like this, you know, with their heads right forward, instead of when the desk is tilted, it would limit that. And the ophthalmologists came up to the conclusion that the eyes work at a very critical angle to the surface. It's something like 18 degrees or something. And if this gets out of that, you will put yourself into all kinds of gyrations to get the eyes to the critical angles. And these desks made a difference. So when we looked at this, or when they looked at this problem, what they suggested was they should go back to the inclined desk for children who were having this problem, that perhaps for a while these children should have a light collar on to stop them getting forward, and that activities within the gymnasium that caused movement forward, like forward tumbling and things like this, should not be done by any of these kids. And they gradually settled down. And so this is very important, and I think perhaps we see some of this when people start having trifocals and all this, and they're hunting around for the line through which to look. You know? This is another thing. And then we've got these television screens where we're doing all this, and we wonder why we get all these repetitive strain injuries that are not recognized by the Workers' Compensation Board. So this anteflexion, headaches in children, is a very, very good discussion on what can happen when we get hypermobility in this area. You know, created by a habit pattern, but there again, if we've got stiffness and so forth, we don't want to be the cause of getting more mobility here. And this is what Evienth was speaking about when he spoke about, you know, keeping that contact in the anterior arch of atlas while we tried to get flexion, rather than doing that kind of movement where we angled up like this, because we try and protect the transverse ligament. You know, I think they're important things for us to talk about. That's why I think when, you know, if you ever get the opportunity to make any presentations with other groups that manipulate who don't want us, we've got to get in there and we've got to give this kind of presentation. Why are these so local for us? Could we demonstrate some techniques? All right, we would never do that. And the reason we wouldn't do that are for the following reasons. We don't understand why you're doing that when these are the consequences. These are our techniques. We've developed them. They're not copied from anybody. So we've got to be much more politically, you know, aware. As I say to you, it'll see me out, but I wonder, about 20 years, whether we're still going to be around.
This is possibly one of the reasons why manual traction works so well on headache pain patients, loosening up the stiff segment on the hypomobile side.
Yes, it may be. It may be. Without putting any sort of threat. It also, you know, when you're doing this, you also tend to sort of get a sense of what muscle's doing and put in, you know, post-isometric relaxation sort of thing. Just hold a bit, now relax, now let me pull it out a little bit more. So you've got those muscle components which come in with headaches as well. Sure. Certainly Bogduck, in an article, I put in 2 articles right at the end of book 2. One is from a Dutch group. That's because Chris was coming on and wanted to sort of celebrate his from the Netherlands, which actually is a very good article by Ansel Delft. Have any of you come across the article by Mead that is constantly trotted up about the efficacy of manipulation by chiropractors in Great Britain and why they should be placed upon the healthcare plan? What you don't understand by this is that the improvement was extremely minimal. It had cost 40% more to obtain this result, which was a 7% improvement, 40% more in terms of cost. And you know what they were comparing? They were comparing the so-called experts, the chiropractors, with just a group of physical therapists in a hospital outpatient department with no special expertise at treating backs. And they almost did as well in terms of improvement at a 40% less cost. We should have been celebrating that, not kind of apologizing for it. And this article, which was produced in the Journal of Manipulative and Physiological Therapeutics by this Dutch group, actually goes through that. And I thought it would be a good idea because this gets trotted out, this Mead study. And when it comes down to it, what you find out was that it was like in a few of the patients, the straight leg raising was like 3 inches higher on one side. I mean, we weren't talking about anything major, and this is what they say. It was infinitesimal when you look at it over a number of parameters. And then I thought I'd put in another article for you so you could celebrate manual therapy. All right? Now, I don't know whether we're all as good as this, but when Bogduck worked with Gwen Jull and looked at headache patients, and she told him where the problem was by manual diagnosis, and he did an injection, those headaches went. And do you know how accurate she was? 100% accurate.
That's becoming I've talked to some people when I was in San Antonio, and one of the things that a therapist friend of mine is getting into is actually doing positioning and palpating and actually having them inject, and he's had the same kind of results.
Yep.
So it's been reproducible.
Yeah, yeah. So, you know, these are the things that we've got to trot out against some of these other studies, and so I put those 2 things in. But I just wanted to sort of point out this thing about headache patterns and so on, and unquestionably the most important level was probably C2-3. I think that's a level that gives us probably more trouble in the neck than any of the others, certainly as far as the zygapophyseal joints are concerned, whereas the disc joint at that level is very rarely affected. Lower down, it's going to be much more the discal joints.
With this hypermobility at that level that you were talking about, and I don't know, this may be only on a theoretical level, would you think that if it stretched out and was hypermobile, would do what any other hypermobile joint would do and lose some of its proprioceptive abilities?
Have you any evidence for that?
Well, not specifically. I haven't taken the time to do it, but I would think that you would just by if you observe movements. I think that you could probably determine that. I haven't specifically taken the time to.
Yeah, there's a very good Finnish study which in the lumbar spine which shows that in many of the cases of instability there was a marked pressure on the dorsal ramus which actually paralyzed the multifidus. And so here we are trying to sort of work the multifida. How do we know that if these things have been paralyzed or not? They were showing complete reaction to degeneration or to denervation, these muscles, when they were done with needle biopsies and things, you know. So I think that certainly a joint that becomes hypermobile starts to lose some of the feedback from the joint, so the thing starts getting worse. Yeah.
I think you can see it more in the lumbar spine.
Yeah.
You can see that little stuttering movement, but
Yeah.
I haven't really looked in that.
It may be just not so easy to sort of tell it as it is in the lumbar spine, but I'm sure it sort of goes on. Let's just take this one, because we don't want to spend all afternoon, you know, looking at these principles, although we can't sort of ignore them. Here's a picture of the transverse ligament, and just to try and illustrate what happens with extension and flexion at this joint, if we take and create our own little atlas on axis like this, it would appear with the osteoligamentous ring that exists between the dens, the anterior arch of atlas, and the transverse ligament, that no flexion and extension should occur here. But we know it does, and almost as much as the joint that looks built for it. Okay, so what we have to think about here is that we can get a slight tilt that goes on in flexion, and somewhere, and it was in Wern's work, I'm almost certain, he described the transverse ligament as being composed of two parts. There was the part round the waist of the dens, which was quite dense, and then there was the part round the upper part of the dens, which seemed to be a little looser. And at that time I didn't understand any of the significance of this, but I've wondered often since whether it's because if we get that motion like this, the upper part can tilt in relationship to the lower part, which gives us that. Okay? Now, if that goes like this at the AA joint, and just ignore what's happening at the OA. Let's just say it's fused, okay? For purposes of this argument, it's fused. And we take that forward like that. What happens to the clivus? It goes forward, doesn't it? That means it's going further away from the dens, which means that flexion of this joint will cause a tightening of the interspinous ligaments, as we discussed. Now then, here's a very interesting thing, that if we take the dens like this, and we've got the atlas around here, the movement of extension is often described as being a slight movement upwards like this, up the backward leaning dens. So we get that kind of movement. Now, if we get that rising movement like this on extension at the atlantoaxial joint, what happens to the clivus? Once again, it goes away from the dens. So here's the very